At this point in time, I think it's fair to assume that not a single person remains unaffected by the ongoing COVID-19 pandemic. Whether you ran out of toilet paper in March, you lost your job, or you lost a loved one, the novel human coronavirus has significantly altered the course of human history. This week on Brainwaves, a podcast about neurology and medicine, I want to speak the truth about the various ways in which COVID has indirectly affected medical care, and why, now more than ever, you should call your mom. Stay with us. Let's consider COVID-19 in the context of previous pandemics. The most recent we've experienced would be the H1N1 or swine flu pandemic back in 2009.
I don't want anybody to be alarmed, but I do want everybody to be prepared.
With early fatality rates suggesting swine flu might be a little more severe than seasonal flu.
CDC show more than 4,000 Americans have died after coming down with H1N1.
But with the final death count for H1N1 totaling about 250,000 people, lab testing only confirmed a small proportion of these.
Again, confirming H1N1 deaths is very time-consuming,
and the total deaths due to H1N1 is already less than the worldwide death count due to COVID-19, just to give you some perspective.
You know, we're now at over 250,000 deaths, 250,000 deaths.
But why did we have better control of H1N1? Well, the first explanation is simple. H1N1 was a milder virus. Here's Dr. Fauci from an interview in 2009.
Most of the time, it's a mild disease, but there are unusual cases that can be severe.
H1N1 killed about 1 per 1,000 symptomatic persons, and interestingly, it sort of spared the elderly population. COVID-19 kills maybe 1 per 100 symptomatic persons, and has a markedly high mortality rate among the elderly. Now, when I do say maybe 1 per 100, it really is only an estimate for COVID. We don't know for sure. Like many pandemics, we don't have great data on the case fatality rate for COVID-19 because of limitations in testing, a wide global variation in treatment strategies, and a highly variable mortality rate based on availability of medical care services. This is also why we saw such a disparity between the laboratory-confirmed fatalities of H1N1 and the suspected fatalities without laboratory confirmation. Even so, H1N1 is definitely milder than COVID-19, and it's less contagious. Which brings me to my next point. The curve for H1N1 infection rates were much flatter than what we've seen with the novel coronavirus SARS-CoV-2. And finally, the Chinese recognition and emergency response to SARS-CoV-2 was twice as slow as our response to H1N1, and a vaccine was produced with greater expediency. Moving on to another pandemic in recent history, HIV.
The human immunodeficiency virus, which causes AIDS.
Acquired immunodeficiency syndrome.
AIDS is now the leading cause of death among young people in this country.
Acquired immune deficiency syndrome. No one with AIDS has been cured.
Originally thought to be a cancer or a possible unusual infection, HIV has remained an ongoing pandemic, claiming the lives of more than 32 million people around the world. This is 10 times more than the number of lives lost during any war fought by American soldiers. But HIV was also unique.
And there was so much that was unknown at the time.
The symptoms of AIDS are often very confusing because...
Although it was first reported as a cancer in the popular media, scientists quickly learned that the virus was spread almost exclusively through sexual intercourse, blood transfusion, and sharing of hypodermic needles.
Needle-sharing drug users joined the sick, as did people with hemophilia.
By 1984, before we even had a commercially available test for HIV, we knew how to prevent its transmission. We had gained a mental control over it. By 1987, contact tracing was ubiquitous, and this led to rapidly expedited treatment of asymptomatic patients and prevention of HIV-associated complications. Unfortunately, due to the ongoing opioid pandemic and poor adherence to safe sex practices, the AIDS pandemic continues.
And 2.5 million new infections happen every year. There is still no cure.
Then there was an outbreak of typhus in 1918, which was not exactly a pandemic, but it claimed the lives of more than 3 million Russians near the end of World War I. This epidemic was greatly facilitated by the Great War, and by the mass immigration of Russian refugees, who escaped in packed train cars in frigid winter conditions, which permitted the rapid spread of the louse-borne illness. Lenin's even quoted as having said, "Either socialism will defeat the louse, or the louse will defeat socialism." Ultimately, a nationwide delousing strategy, combined with isolation of the sick and education of the healthy, led to control over the epidemic. One Red Army disinfection room was even documented as having a 2-inch thick floor of dead lice, where soldiers would come in for treatment. At the same time as the Russian typhus epidemic, Spanish flu was even more pervasive, responsible for an estimate of over 50 million deaths worldwide.
Killed more people in the first 25 weeks than HIV/AIDS has killed in 25 years.
Making it the worst natural disaster in all of recorded human history.
Oddly, Spanish influenza preferentially impacted the lives of young people in their 20s and 30s. And like we're seeing with COVID-19, Spanish flu came in several waves, with the first wave being generally mild, like the seasonal flu. And then a second wave took off in August of 1918, presumed to be a more virulent and lethal strain of the virus. Although the rapid disappearance of Spanish flu is not easy to explain, some historians credit the response of many European countries that closed schools and locked down barracks for soldiers who were returning from the Great War. When these measures alone did not curb the spread of Spanish flu, some European nations escalated public health measures, preventing public gatherings, closing theaters, restricting passengers on public trains and ships, and government-sponsored education to improve health literacy. Sick patients were isolated in infirmaries and local hospitals, sanitation of streets and public facilities became prioritized, and early forms of contact tracing and surveillance were being explored. Like we've seen today, mask wearing was controversial at that time as well.
Masks were never officially mandated on the East Coast, but other health rules were often aggressively enforced.
And whether it was these public health efforts, or just the natural history of the virus, it seemed to go away as mysteriously as it emerged. Although we cannot know for certain how these pandemics originated, and how many of them fizzled out, several important themes may account for the successful control of an outbreak. First, tracking and isolating the potentially infected. By this, I mean contact tracing.
Contact tracing is a highly effective cornerstone of infectious disease mitigation that is regularly...
And we've had a lot of trouble doing this with the COVID-19 pandemic, which has only become more difficult as the virus has become more rampant.
It is most effective in places where the number of circulating cases is low.
But that doesn't mean it's impossible to do. Looking back at 1987, contact tracing was nearly mandatory for patients who were diagnosed with HIV/AIDS. And in 1918, European cities and countries were actively tracking where and how many people were infected with the Spanish influenza. A second theme from prior pandemics: understanding and controlling the route of infection.
It's found in blood. We now know it's found in semen, and we also now know it's found in saliva.
Recognizing HIV could be spread through sexual contact, needles, and blood transfusions was instrumental in flattening the curve. Knowing that Russian typhus was spread via lice facilitated the enormously successful delousing program. And having learned that COVID-19 was spread via respiratory secretions was the earliest chink in its armor, and one that America tried to exploit early on.
We have urged Americans to wear masks.
But encouraging mask wearing may not be enough. It's the simplest thing: wear a mask.
Maybe they're great, and maybe they're just good, maybe they're not so good.
If any conclusions can be drawn, masks are definitely not bad. Just a few weeks ago, a paper came out in the Morbidity and Mortality Weekly Report, reporting what happened when the state of Kansas tried to implement a mask-wearing policy.
That's basically when the mandate goes into effect.
Counties that mandated mask wearing saw a 6% decline in new cases.
It basically stays flat in the 20 counties with the mask mandate.
Whereas those who did not mandate mask wearing saw a 100% climb in new cases.
2 weeks after the mandate was issued, the cases started climbing in those counties. And then in mid to late August, the case numbers just took off.
A third theme: swiftly and effectively implementing government-level policies in order to educate the public and encourage preventive health measures. Mexico and the U.S.'s response to H1N1 were twice as quick as China's response to SARS-CoV-2. Then there's also Russia's mandatory delousing program, and adoption of new public sanitation policies at the end of the Great War. These may all have been coincidentally related to control of the pandemics, but let's think about Taiwan's response to the COVID-19 pandemic, which has been phenomenal. A country home to more than 24 million people, Taiwan had already established quarantine protocols, contact tracing, and mask-wearing policies. And because of these systems-level public health mandates, Taiwan has been home to fewer than 1,000 cases of COVID-19, with fewer than a dozen fatalities. I'm sure none of this is news to you. If you're listening to the show, none of what I've said is really that surprising. But let's take a step back further in history. Before these 20th century pandemics, our knowledge of infectious disease was fairly limited. Robert Koch, who was the first to formalize criteria identifying agents responsible for transmissible illnesses, Koch proposed 4 key criteria in 1884, and these 4 criteria took decades and major advancements in medical technology before they were widely accepted.
Microorganisms must occur in abundance in all organisms suffering from the disease. The microorganism must be isolated from the diseased organism. The organism must cause the same disease when exposed to a healthy. The microorganism must be re-identified from the newly infected host.
Before that time, all we'd really presumed about certain illnesses is that they can be transmitted through bad air, or miasma, or perhaps via contact with surfaces, a concept that evolved into what's now referred to as transmission via fomites. In many regions of the world, particularly in Europe, many believed you could prevent illness by avoiding people who were ill. Isolation from the sick. Straightforward and intuitive notion, but it was one that had emerged after centuries of a failing humoral theory and incomplete understanding of human anatomy that was based only on animal models. And let's take a deeper dive into that concept, the concept of isolation or quarantine. You might have known this already, but quarantine was a concept that emerged during the time of the bubonic plague, a time in which ships arriving to Venice would be forced to remain in isolation for 40 days. Quaranta is Italian for 40, and they would remain docked in order to prevent the spread of plague into Italy. 40 days is a long time. 14 days is also a long time, especially when you're thinking about avoiding all social contact. But I don't need to tell you that. What I do need to tell you is what can happen during those 14 days, or 40 days, or even the last 9 months that at-risk community dwellers have been socially avoidant. What can happen as a consequence of isolation? When it comes to the consequences of isolation, we're talking about the at-risk community dwellers, your parents, your grandparents, the elderly. And here's what we know. First, older patients left in isolation are more likely to develop anxiety and depression, loss of a sense of belonging, exclusion from places of worship and community centers, restriction from social networks, and limitations of daily visitors, who can include family, but also include health aides. And this has enormous consequences for the elderly. While healthcare officials and administrators are prioritizing the physical health and survival of this at-risk population, it comes at a cost in mental health. And it's not a cost that many are willing to pay. SARS-CoV-2 is far more contagious and far deadlier than many other pathogens from our time, twice as contagious as seasonal flu with a higher mortality rate, and it's a virus that the elderly want to avoid since they're dying at a disproportionately higher rate. So what can you do? Call your mom. Call your dad. Call your grandma. Hop on a Zoom or FaceTime. Plan a movie night. Adapt to the physical isolation by adopting new ways to interact with your family safely. Normalize this loss of social engagement. Second, older patients are at higher risk of many acute and chronic diseases. We showed this at Cooper, where I work, early in the pandemic, and other groups have shown this in other cohort studies, but older patients are avoiding the hospital. They aren't coming in because they feel well. They're not coming in because they're afraid of the hospital. They're more afraid of the hospital than they are of the local grocery store. In one of the largest cohort studies published in JAMA Internal Medicine, Jeffrey and colleagues described findings across 24 emergency departments in 5 states: New York, Massachusetts, Connecticut, Colorado, and North Carolina. Declines between 40 and 60% in ED visits were reported at the outset of the pandemic when compared to previous months. And it's not just acute care that's affected. Primary care and management of chronic conditions is also suffering because of the pandemic. Consider a report out of the Netherlands, which reported a decline in cancer diagnoses of 25% in late spring and early summer of 2020. Do you think that fewer people are actually developing cancer? No. Patients are avoiding their doctor. They're avoiding the hospital. And they're avoiding measures that are set in place for appropriate screening, early detection, and the timely treatment of often fatal conditions. Sure, maybe some of it's related to less outpatient availability or changes in practice paradigms to prevent more infections and spread of COVID in the hospital setting, but it's also a social consequence. People don't want to go to a place that's teeming with COVID-19 patients. Moving forward, what is one thing that we can take away? Well, let's forget about COVID-19 for a second. Everyone's talking about it. You're either drinking the Kool-Aid or you're not. Let's think about seasonal influenza, the flu.
Let's say if you think you have influenza.
A milder condition, but much, much more common.
Most of the time, this is a relatively mild illness. It makes you uncomfortable.
Despite it generally being a milder viral illness compared to COVID, influenza A and B kill about 500,000 people every year, according to 2012 estimates. Now, that's a lot. But already 3 times that many people have died from COVID-19. When thinking about the flu, for every individual who dies of it, 9 others develop a severe respiratory syndrome. 1 billion are ultimately infected, and they're at risk. And this is every year. Now let's say for every person who's expected to die from the flu, those 9 others who will also get sick, about 5 million people worldwide, say they don't seek medical attention. I'm feeling all right, they say.
Some sniffles, a bit of a cough, and it doesn't go.
I don't need to go to the hospital. Or the person might tell you, if it's COVID, I should just stay home and not get anyone else sick. This is not the right way to think about it. Those 5 million who get really sick from influenza, many of them receive acute life-saving treatment when they seek medical attention.
You may want to call up your healthcare provider, explain your symptoms.
But if they don't call their doctor, if they don't come to the hospital when they need to, as we've seen in patients who are dying at home of heart attacks, strokes, cancers, overdoses, and other conditions, if they don't come to the hospital, what do you think is going to happen? So what can you do? Call your mom. Hey mom, how are you? Check in with your parents. Hey dad. Call your brother or your sister, your cousin. Call your aunt who has diabetes. You don't have to make sure that they're brushing their teeth or paying their bills. But maybe you can ask, have you talked to your doctor lately? Are you checking your blood pressure? Do you need me to pick up any groceries for you? What I don't want you to take away from our program today is that we need to be more social, at least physically social. We can remain social in virtual environments. As I mentioned before in the program, my family's been doing weekly Zoom calls. I've also done online workouts with friends and virtual happy hours. Together, my family watched each of the presidential and vice presidential debates, and you can do movie marathons or binge a new series on Netflix. My grandmother's been in a book club. You can do all these things, and hopefully not for much longer. The coronavirus vaccine that was developed by Pfizer and BioNTech and many other vaccines are going to enter commercial distribution by the end of the year and in early 2021, with hundreds of millions of vaccines becoming available in the next 12 months. So be patient. Be safe. Know that you're not alone. The light at the end of the tunnel is near, and until you get there, call your mom.
Affect current protocols? What would people have to do differently, essentially, to protect themselves from COVID-19?
It requires some adjustments, right?
People just need to place more emphasis on some of the things we're already doing.
At least we can do it virtually.
Social distancing.
Wash your hands frequently.
And making sure we're using as much outdoor air as possible, avoiding crowded spaces. And
keep that gathering as small as possible.
What should you do?
You can't isolate yourself from the rest of the world for the whole flu season.
The stress of not seeing each other or even trying to see each other in that.
The real pandemic is mental health.
The care has to address psychosocial issues as well.
It's more difficult to stay socially distanced from people.
I think the most important thing is just to keep making connections.
Through the technology, through Zoom. Just be connected with people.
That's what's important.
That's it for another week of the Brainwaves podcast. Thanks so much for tuning in. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision making. I hope that you'll take everything I said today here with a grain of salt. Maybe you talk to your parents and grandparents already too much, and maybe you need some space. Mental health is so important. So if you need a break, take one. Maybe your takeaway from this program is that you should not call your mom. But whatever your takeaway is from the show, none of what was said today should be used as any kind of evidence-based guideline, just my own thoughts and encouragement that you should do what you think is safe. And maybe call your mom. This week's episode of Brainwaves was produced by myself, Jim Siegler, out of Studio 3 in Philadelphia, Pennsylvania. Music for our program was courtesy of Purple Planet Music, Maiden, Kevin MacLeod, and Shane Ivers, which you can find at silvermansound.com. Our theme song was composed by Timothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed on the show, with all the references, you can take a look at our show notes and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.